Good morning, everyone. Welcome to Family Day, Week 3. For the newer faces, the folks I have not met yet, I'm Dr. Slutton. I'm the Clinical Director of the Pain Rehab Program. And I'd like to start off this time that we have together with a few introductory comments and just to kind of orient everyone to what's happening today. Family days are a very, very big part of pain rehab. As we go through the 3 weeks of the program, a lot of information, a lot of change, a lot of work is being done by the folks going through the program. And we have found it very helpful that when family members can come in and hear and understand a little bit about what we're doing, it makes your ability to support the process better. And so that's one of the reasons we have Family Day. Family Day is divided into two parts. The part we have here together is the combined part, so folks in the program, available family members, and what we accomplish in this hour is reviewing some of the major topics that we talked about this week. Quick word about how the program is organized. There's a 3-week curriculum that we work on in the groups that I do. There's a 3-week curriculum that occupational therapy does. There's a 3-week exercise plan. Nursing supervises medication changes. So there's this rotating schedule that we apply, and it doesn't matter when a person starts, you're going to get all the material at one time or another. But every Monday we cover an important topic of the week, and we review that again this morning so that if you came in during the week, you get a refresher. If you heard it Monday morning but were only semi-conscious, you get to hear it again Friday morning. Hopefully you're more awake today. But we're going to repeat the information so that everyone hears kind of the big topics. This morning's big topic is pain behaviors, and I'm going to review those in just a few minutes. The other thing I like to do every Friday is go over the model, expanding a little bit on what we saw in the video, expanding a little bit on what happens in some of this issue of central sensitization. So we're going to start with that this morning. Next week, we will spend more time talking about the actual mechanisms of central sensitization. That will be the big topic for next week. But every Friday, I feel like it's helpful because if you only get to hear this once or you hear it a few times, understanding sort of the complexity and the change that occurs as this process happens, as symptoms become chronic, I think can help in a number of ways. It can help explain some things, which is nice. But it also, much more importantly, gives us a direction moving forward of what to do about some of these changes. And so when we look at the human nervous system, we can generally divide it into central and peripheral. Central nervous system being brain and spinal cord. Peripheral being sensory, motor, and autonomic. We'll mostly talk about the sensory system this morning. But in the body, every square inch of our body, there are tiny little neurons, little sensor cells that are there to do one job. In the back of our eyes, we have photoreceptors to detect a specific wavelength of light. In your skin, you have receptors for temperature and touch and all sorts of things. Our digestive system has sensors to tell us about the state of our digestion, hunger, fullness, all kinds of things. So everywhere, inside and outside of our body, we have these sensors. So I'm going to list the main areas just so that we keep a perspective here. But we have it in our skin, our digestive system, our musculoskeletal system, our balance system, the blood vessels, nerves, our basic senses, vision, hearing, taste, smell. The reason I make this list and I emphasize sort of the all-encompassing nature of this is symptoms can arise from anywhere for any number of reasons. And so our patients that come to the program have a myriad of medical histories that can be quite distinct from one another. But the consequences are the common thing. As we've talked about several times in the program, our patients come to the program not because of their medical diagnosis, but because of the impact of that diagnosis. And so when we talk about what happens, we need to understand that it's not your specific list of diagnoses in your medical record, it's the impact that it's had on your life. And the fact that it's not just pain that we treat. We're still called pain rehab. We've been called that for more than 40 years in the Mayo system. But this is really a symptom rehab program. We're really addressing people that have chronic symptoms of all types. Nausea and vomiting, dizziness, weakness, fatigue, itching, burning, tingling, all kinds of things that may or may not be necessarily painful. We also treat people that have movement issues. Muscular movement problems also falls under this rubric, as I'll mention in a minute. So I always want to emphasize thinking as broadly about this as possible, because it's very easy to think, well, I'm just here for my neck pain, not really my dizziness, or I'm just here for my knee and not my headache. It's all pollution in the same river. It doesn't matter the source at any one time. It's affecting the body and the brain in the same way. So with that increased signal from the body, we have this upregulatory process a stronger signal going to the brain, excuse me, and we end up with what we call the sensitized somatosensory cortex. This is the part of the brain where all of your body sensations go for registration and analysis. So whether it's an itch or a burn or a tickle or a sweet taste or whatever, it goes to this part of the brain. And this part of the brain is organized by body part and not sensation. So anything that happens to my right hand would register in the right hand part of my brain, okay? And the reason that's important to understand is that symptoms can spread, symptoms can diffuse through the body based on the organization of the brain. That's why we can account for people that start out with an arm problem and now their whole upper body hurts, or they start out with one digestive issue and now their whole digestive tract is messed up. So that's just by way of explaining that. The second system that can be impacted in the brain is the motor cortex, the movement part of the brain. And the reason it's important to understand this is with sensitization, some people develop movement difficulties. Everything from twitchy, tremory muscles to episodes where they can't control body movements. And that's another thing that we see in the program on a regular basis. So the consequence for the person that this has happened to is symptoms can proliferate. So we can see more pain, fatigue, dizziness, nausea, numbness, tingling, etc. There's a proliferation of symptoms, and there is often a proliferation of triggers: light, sound, smell, taste, touch, movement, temperature. And so the consequence for the person is it takes less to hurt, more things cause the hurt lasts longer. That's kind of the consequences of central sensitization. And as I review every week, and I just feel so strongly about this, it's important to understand there's no psychology in this process. This is not a psychosomatic illness. This is not hypochondriasis. This is not a conversion disorder. There's no deep-seated neuroses because you weren't potty trained the right way that caused this problem, okay? That's just all a bunch of Freudian nonsense psychobabble. This is a physical change. And for some in the program, the physical change happened for very obvious reasons. We have folks that could pinpoint the minute that they really felt their symptoms took off. There are others in the program that the symptoms just percolated for a long time and then suddenly became more difficult to manage. So we see all different trajectories. That's not the important part. The important part is the consequences are universal. And so whether a problem has kindled for a while and then suddenly got flared up, or it's been there on and off for a long time, whatever the process is not as relevant as the impact. There's a second implication before I move on, and that is, just like there's no psychology here, there's also no more space for medical interventions. This is why, coming into the program, we're asking you to take a completely different view of what to do. Every patient that I have ever worked with, in many ways, has been medically treated to the nth degree. Shots and creams and therapies and surgeries and spinal cord stimulators and on and on and on it goes. And the problem is any somatic treatment at this point, whether it's in the body, central nervous system, or anywhere in between, is too little too late. You can't unsensitize the sensor, you can't block it at the spinal cord anymore, and you can't fix it in the brain. And so all the efforts to manage this become less productive, more impactful on the person, and we actually see damage and potential for damage get worse over time with excessive medical treatment. We'll come back to that at another time. Now, in the program, the place that we can make a difference is what we call the 4 reactive and maintaining factors. These are the 4 areas that we can actually help a person change. These are the 4 areas that are feeding the fire. If you think about this part of the brain like a forest fire, these are the factors that keep making it worse. Physical deconditioning, changes from surgery, changes from disease progression impact the body. And our patients come to us deconditioned, less able to use their bodies than they once were. Emotional distress, stress, anger, anxiety, depression, all feed the emotional fire and need to be addressed in the program. Didn't cause it, you've heard me clearly say that, but it sure can jump on the bandwagon in a big hurry, and so emotional dysregulation is a big deal. I'll come back to behavioral in a second. The other area is chemical. Polypharmacy, excessive use of medicines, trying to find the right balance of medicines to control the brain becomes a losing proposition. The body habituates, the medicines need to get stronger, the impact can be greater. Lastly, behavioral. There's 2 behavioral issues. One is pushing and crashing. So our patients, the folks that come to this program, have been, by and large, very busy and active folks. They like to be involved in life. And so historically, when they felt better, when you felt better, you got up and tried to do things. And you wanted to make as much progress as you could when you felt well, make hay while the sun shines, stirred everything up, and then crashed. And the pushing and crashing, as you can see, I hope, directly feeds this fire. Because every push stirs up symptoms, every crash takes a little more out of the person's strength and stamina. So there's a huge impact from that. We'll talk about some of the emotional consequences of that in another session. The behavior I'm going to focus the rest of our time on this morning is pain behaviors. Okay? I'll write up a bunch in a minute, we'll talk about them, but pain behaviors are those things that a person says, does, or thinks that reminds themselves or others that they're having symptoms. Okay? You notice says, does, or thinks pretty much encompasses all of humanity, doesn't it? Okay? It's pretty much anything could be a pain behavior. Here's why it's such a big deal. Part of this process is a sensory memory. When you've had sensations, you develop a sensory memory, you develop a recollection of that sensation, good or bad. We could sit here this morning and for a moment pause and think of our favorite flavor. Or we could think of a scent, a fresh cut grass or coffee brewing or something, and you could almost feel like you're re-experiencing it. And when we have a sensory memory, we are actually activating some of the same parts of the brain that are active when we're experiencing that thing. I'll give you 2 research examples. Several years ago at Stanford, they did a study with back pain patients. They put them in a functional MRI machine, a machine that measures brain activity in real time, on a bad pain day. And they mapped out what their brain looked like, and it was quite active, quite a few spots firing off. They took the same patients on a low pain day, put them back in the machine, and the brain was much less activated. Then, while the machine was still on, they told the patients one thing: think about your back pain. The brain lit up like a Christmas tree. Because simply activating a sensory memory of their pain problem activated the same pathways that were already there. In a non-pain study, which I think this is kind of fascinating, there was a similar study done with concert violinists. They took very accomplished musicians, put them in an MRI machine, and asked them to think about a piece of violin music. And as you could imagine, a lot of their brain lit up, because if you're a concert violinist, you're probably hearing, seeing, thinking about what you would be doing with your hands. A lot of your brain is involved in music if you're the musician. They contrasted that with non-musicians who knew that piece of music, and that very little of their brain lit up, a little bit of the auditory cortex and a few other places, because they weren't as intimately involved with the music. We see the same differences in pain patients versus non-pain patients. Someone without chronic pain will have much less brain activity when they experience a painful stimulus than someone with chronic pain. So we're fighting a battle where so much of the brain is involved. Our only chance of helping folks is to cut off the fuel sources. We have to stop feeding the fire. And here's the issue. And this is non-negotiable, not my rules. You have to be all in on all four. You can't pick and choose. No one has ever successfully done PRC. No one has graduated. No one has gone on to having a great quality of life after the program that just did 3 out of the 4. This isn't a Chinese menu. I'll have the Kung Pao chicken and lo mein, but no egg rolls. You don't get to choose, okay? Because any source of fuel will keep this activated. And that's why we're so strict on pain behaviors, because if we don't break the pain behavior cycle, it's a constant drizzle of fuel into the fire. And there's some that are very hard to break. There are others that are easier. I'll go over those in a minute. But it's so important in families. You're here to help us out. The folks going through the program, you know this. We have to be very diligent and disciplined to break this cycle for there to be any positive impact. So let me illustrate. And this could be labeled, I still stuck with old words, this could be labeled symptom behaviors. Anything a person says, does, or thinks that reminds themselves or others that they are in pain or having symptoms. This is a pretty broad definition, because anything falls into the anything category, which can be anything, okay? And we're talking about thinking, saying, or doing. That's pretty much everything about us. And it could be for us or it could be for someone else, so it could be interpersonal or it could be just personal. This is a big deal. And I'm going to categorize some pain behaviors to illustrate kind of a progression. So the first group of pain behaviors we're going to talk about are what I call the low-hanging fruit of pain behaviors. Limping, moaning, groaning, rubbing, holding, talking about. The reason I call this a low-hanging fruit is if you saw someone doing this on a bench or walking down the hallway, you would know that they're struggling with something. They're very obvious expressions of suffering. And they're usually pretty easy to break in the program because as a person goes through the program, they're going to experience some peer pressure. When you come into the program, if you can continue to exhibit pain behaviors, people are going to ignore you. Now, we call that supportive neutrality. It just makes us feel better about things, but we're basically ignoring you because those are maladaptive behaviors. We will be instructed in ways to break some of the habits because all of these feed that fire. Now, the insidious one I want to spend just a few minutes on is the talking about. This is a tough one. People come into the program, brand new, look around. Hey, what are you in for? And all it takes is one conversation about your medical history, your surgical history, the medicines you've been on, the therapies you've had, the number of operations, the days spent in ICU last year, whatever, and it's on. You've just lit up the pathways we're trying to calm down. And when someone talks to you about it, their problem, it lights up your pathways. And so the folks going through the program, it is so vital to not talk about anything related to your health. No treatments, no diagnoses, nothing. Because a couple things happen socially. We get into war stories. Well, I have this scar because I had a tracheostomy after 16 days in the ICU with MRSA and my spinal fusion, and all of a sudden it's off to the races. Talking about how well or poorly someone slept, digestive health, mood, all of that feeds right back into this. So we're very, very strict in the program to not talk about it. And the folks that have been here for a minute will tell you it really starts to bother them when you talk about your symptoms. So what I notice a lot is the folks that have been here for a while sit in the hallway between groups, and the newbies are in there swapping war stories. And we want that stopped. Families, you can help. Stop asking how they feel. You're like, well, that's just so harsh. It's necessary because you're not being loving anymore. You're feeding the circuit. And they're actually being selfish. So find other alternative phrases like, I love you, I'm proud of you, way to go, you're so courageous, be strong. Those are all awesome things to tell a person. Not, you look tired, are you okay, do you need a pain pill, maybe you should go lay down. Those are harmful things to talk about. And the talking about also can involve scanning, because the minute someone asks how you're doing, you might be doing okay, but the minute they say something, you start scanning to figure out how you're doing. So this is an extremely, extremely important part of the program. And it's one that people struggle with, frankly, because it's a hard habit to break. And that's what we're here to help with. All right, next column. The Walgreens column. The reason I call this the Walgreens column is this is stuff you can get at a retail drugstore. If you notice the layout of a retail drugstore, they're pretty much universal. You walk in, the cashier greets you, welcome to Walgreens. There's overpriced cosmetics, there's greeting cards, stale, outdated food, and then 5 aisles of pain behaviors before you get to the pharmacy. And it's all strategic. It's all about selling stuff, right? Because while you wait for the pharmacist to very, very slowly fill your prescription, you're going to walk up and down the aisles and see what's new. Oh, Shaquille O'Neal has a new thing I can put on my body that emits heat and vibrates. Oh, Salonpas is now in strawberry lemon. I think I should try that one. There's a new brace that will go along with my outfit for Sunday. And it's just pain behavior after pain behavior after pain behavior. And the reason I put this up besides all that is some of this works for a minute. Ice will always numb. Heat will always warm. Icy hot will always stink. It's just an immutable property of those things. And people are like, well, my doctor said I should try that. I know, back when everyone thought this was going to go away. That was 10 years ago. But there's nothing in this list over-the-counter medicines, prescription medicines. There's nothing in this list that's going to fix this problem. But everything in that list can feed the problem. So we need to break out of that cycle of going and looking for remedies. vitamins and supplements. The list could go on and on. They're all potentially pain behaviors because you're taking them for a symptom, you're telling yourself and others that you need it, and it's not really fixing anything. Next list. The practitioner list. Visiting MDs, chiropractor, massagers, any kind of therapist, whatever you went to for your symptoms could feed into the pain behavior cycle at a very elemental level. What are the questions that practitioners ask their patients? How are you feeling? Where does it hurt? What should we work on today? How did my treatment work last week? Think about it, think about it, think about it, talk about it, talk about it, talk about it. And if they're going to mash on your body in some way, they're going to stir up the circuits directly by amplifying the feedback to the brain. In medicine, in healthcare, we are compelled to ask pain scores. It's called the fifth vital sign. So when you go to a healthcare provider, they're compelled to ask you what your symptoms are. My colleagues down the hall in the pain clinic, we have a pain mannequin that looks like a CSI body outline, and you get to fill it in with all your symptoms, you know, little squiggly lines for burning and X's for numbing or whatever. Think about it, think about it, think about it. So this is a very slippery place. And again, none of this was fixing you. None of this was restorative. It was simply trying to treat or tamp down symptoms temporarily, and you had to go back for more the next week or the next month. Media. So we have the mass media, the Dr. Oz's of the world that just spread and disseminate nonsense. Dr. Google, who isn't even a real doctor, okay, but you can consult him with your symptoms any day of the week, 24/7, just type in headache, and guess what pops up? Brain tumor, aneurysm, stroke, okay? It never comes back stress, you drank too much last night, go get some exercise. It's always the killer stuff. And here's the problem with researching. None of us in this room is qualified to research our own medical history or our own diagnosis. And in fact, the problem with the internet is that we have unfettered access to highly technical material without a context. And we try to connect the dots and it just gets more confusing and worse for us. So we strongly admonish people to get off the internet, stop looking at the symptom finder index, et cetera, et cetera. Social media. Bleeding all over Facebook about it's just a bad day today, just, you know, just really could use your thoughts and prayers and, you know, give me a like if you want to help me or whatever. It's just a huge pain behavior. And even more focused is the blogosphere, okay? People blogging about their medical misery. It just never ceases to amaze me how as humans we just want to trot out our patheticness. And in the blogosphere, people even name themselves after their conditions. Fibromyalgia patients calling themselves fibromites. Had a lady one time that had a Chiari malformation, a malformation in her brain. She called herself a Chiarian. Now, I restrained myself, but I wanted to say, welcome to our planet. I hope you come in peace, right? From planet Chiari. I mean, it's ridiculous. If you've named yourself based on your symptoms, get a different hobby. You're way more interesting than your diagnosis, but people do that. And the other thing about the blogosphere is people just complain about how miserable they are and how medicine can't fix them, et cetera, et cetera. It's nothing but a certified complaint session. It doesn't accomplish anything. Next list. Lifestyle. Hair, clothing, hygiene, makeup, glasses, anything that you can alter and did alter based on how you felt could be a pain behavior. It's back to the message to yourself and others. If you wear certain clothes on bad days and other clothes on good days, you might as well have a neon sign on your chest saying it's a bad day. When mom shows up to the breakfast table in her pain t-shirt, the whole family knows we're not going to Walmart today. If you don't wash your hair on bad days and you wash it on good days, you don't wear makeup on bad days, you wear it on good days, glasses on bad days, contacts on good days, anything you alter on a consistent basis based on your symptoms is sending a message to yourself and others that you're having pain. And so we don't really care, and we want you to wear clothes and we want you to bathe and all that stuff, but we don't really care what you choose to wear, but it needs to be consistent. Because even for yourself, it sends a message. Remember when you were a little kid and you woke up and you told your mom, I don't feel like I can go to school today, and your mom said, why don't you get dressed and have breakfast and we'll see how you feel. And before you knew it, you're on the bus, okay, and you're actually feeling a little bit better. Just getting up and taking care of yourself can have a huge positive impact. 2 other lifestyle issues. Furniture and pets. Furniture is just your environment. Are there things in your home place, in your domicile, that would scream pain behaviors? The hospital bed in the TV room, the ice packs in the freezer, heating pads plugged into every outlet, warm fuzzy blankets on every piece of furniture, whatever. And some people don't have a lot of this, other people have a lot of it, but it's just worth examining, because if your environment speaks pain behaviors, you're going to be reminded of your pain behaviors, and so is everybody else. Pets. I love dogs, tolerate cats, okay? But pets, and dogs in particular, have been now overused as companion or comfort animals for people with chronic symptoms. There is no need for a fibromyalgia dog, okay? You roll into Walmart with your Chihuahua with the service dog vest on, and what do people say? Oh, I know I can't pet her, but why do you have a service dog? And you're like, well, I have fibromyalgia. It kind of keeps people away. I really shouldn't talk about it. Pain behavior, pain behavior, pain behavior. It just screams pain behaviors. You don't need a dog for your symptoms. Now, there are noble and very important uses for service animals. People that are visually impaired or people that have mobility issues and certain medical conditions. I'm all for that. But a comfort or companion animal for symptoms is completely, it's crippling, number one, and it's a huge pain behavior. So take the vest off the Chihuahua. Number 2, some of you are sitting here self-righteously saying, well, I would never do that. But my Mitzi just knows when I'm struggling with symptoms. She just crawls in my lap and she just comforts me. You know why Mitzi crawls in your lap and comforts you? Because you're like, come here, Mitzi, mommy's hurting today. And Mitzi crawled up in your lap and you praised her and gave her a treat. You trained her to do that. She can't sense your pain. She can sense your immobility, and she's looking for an opportunity to take a nap. Use your dog as a motivation to walk and not sit on the couch all snuggled up with a living heating pad, okay? So dogs are great. Motivate, walk, let them outside, take care of them. Don't sit there and just cuddle with them, okay? Because here's the other thing. Your family comes in and they're like, well, there's Dad and the poodle. I guess it's a bad day, because Dad's got his pain poodle. So just be aware of those behaviors and the messages you're sending. Next column, PRC. Anything we do in the pain rehab program could potentially be a pain behavior. We do things on a schedule here. We do things to help people function. Those are the 2 important issues. But any one of the things that we do during the day, your exercises, morning stretches, diaphragmatic breathing, relaxation, anything could be twisted into a pain behavior. And this gets to the core issue that what we talk about a lot. There's 2 questions for someone to ask to tell if something's a pain behavior or not. Why am I doing it and when am I doing it? And if the why is for symptoms and the when is when you're having symptoms, it's pain behavior. So we do morning stretches in the morning to get people limbered up, get them moving. Well, if someone breaks into morning stretches at 2:38 in the afternoon because they're stiff and sore, that's a pain behavior. So a good thing can be twisted into a pain behavior. We teach our patients to diaphragmatically breathe and do relaxed breathing. We want them to do it all the time. But someone pulls back and breaks into some deep breathing, iguana method or something, because they're having symptoms, that's a pain behavior. And physical therapy, occupational therapy, and psychotherapy, as we practice it in the program, are all designed to help an individual be autonomous and not need ongoing therapy. No one graduating from the program needs to go back to a physical therapist, okay? Because if you go back to a physical therapist on the outside, it's going to be pain behavior, talk about it, what am I going to work on, etc. We're teaching you to exercise and manage your body on your own. Most people don't need to go back to counseling for their pain and stress related to their pain. We got that covered. Now, if people need psychotherapy for something else, please understand I'm all for that. I'm a psychologist, okay? But pain-related, stress-related psychotherapy serves no useful purpose after the program. You already know the answer. You don't need to go every week and get an emotional hug from some therapist that tells you how brave and strong you are. So these things can get twisted into a pain behavior in a big hurry. So if the why is because of symptoms and the when is when you're having symptoms, the real answer is why I'm doing it to function, and the when is on a schedule. Now I'm going to take a moment here. We have just a few minutes left. Let me talk to the family members for 1 second. Before we finish this morning's session, I want to admonish you and request something from you. The admonishment is, you've just heard an explanation of pain behaviors. I am not deputizing you as part of the pain behavior police. You are not allowed this weekend to walk around and start pointing stuff out. Is that a pain behavior? Is that a pain behavior? Why and when are you doing this? Just leave the person alone, because you'll have a very long and annoying weekend if you become the pain behavior police. Folks in the program, this is on you guys. It's not my job. It's none of my colleagues' job. It's not your family and friends' job. It's your job. And once you've been told about this, we're pretty much going to ignore you if you don't comply, unless it gets so egregious that we have to stop you, because you're only hurting yourself. So family members, you don't have to jump in and monitor this stuff. You may notice it, but it's not your job to stop it. It's really on the folks going through the program to manage this, okay? But it is a critical issue. One last thing before we finish. It is also a temporary issue. This stuff won't even matter in a couple of months, pain behaviors. Someone will come up to one of you after you've graduated from the program a few months from now and like, hey, how you doing? And you'll be like, good, how are you? And it's no big deal. But right now, words are so important, thoughts are so important, behaviors are so important, because we're trying to put out this fire. So folks going through the program and family members, don't worry that this is going to be a major issue in your lives months from now. It becomes less and less prominent. People get a little more immune to it. But right now, it is a delicate, important issue to be managed. 2 final pain behavior, or 3 before we stop. Pizza, pineapple, and potatoes. Pizza, simply to remind us that some of you have altered your dining behavior based on your symptoms. Some come through the program and they have not sat in a restaurant in years because it's too hard, the sounds, the smells, whatever. So you've done takeout to avoid sitting in a restaurant. That's pain behavior. Some of you do takeout on pain days because you don't feel like cooking. That's a pain behavior. So I don't care if you eat out or not, I don't care if you take out or not, that's not the issue. It's why and when are you doing it. Pineapple. This was a 3-level pain behavior that a patient confessed to a few years ago. She saw on Dr. Oz that pineapple have anti-inflammatory properties, so she ate a pineapple every day. And the great irony is she hated pineapple. She was very happy to give up that pain behavior, but she had been doing it for very dumb reasons. And then the last one, true story, we had a patient several years ago who traveled with a 10-pound sack of potatoes because they read that pressure points help headaches. And so this person would sleep with a 10-pound sack of potatoes on their head every night, okay? We literally did a potato taper. We had that person bring a potato in every day to the program, and we made potato salad. Okay. Now this was up in Minnesota, so it was a light vinaigrette sort of German potato salad, not the heavy Duke's mayonnaise potato salad that we eat down here. So, but it can be really ridiculous. So it's very important to understand, why am I doing a behavior and when am I doing it to break the habit? All right? That concludes the lesson. Have a good day.